in pursuit of health and wisdom. Sapio with Buck Joffrey.
So my guest today on Sapio with Buck Joffrey is Rob Hamilton. Rob, welcome to the show. You have the distinct privilege of being the first remote guest on the Sapio podcast, and so that's good or bad. I'm not sure. We'll find out soon. But luckily we've got Ben here, the master of all the IT things. But Rob. Let's start out with this. Well, I mean, tell us a little bit about your background, because you started out actually as an ER doc, right? And tell us a little bit how you got interested in these other arenas, and the types of training that requires and stuff. I know there's some various certifications and all that. Tell us about how that works.
Sure. So I started out very solidly in the camp of emergency medicine. So the natural enemy of the neurosurgeon, as you're aware, because we're the ones who called at 3 a.m. saying, here's an epidural hematoma, you need to operate on it in 5 minutes here.
You're the reason why I quit, basically.
Yeah, probably specifically. It's an ecosystem of sorts. But anyways, practiced emergency medicine for about 20 years, sort of thinking that this is the be all and end all. But I was also kind of frustrated because I realized that a lot of what we were seeing was very preventable. And a lot of the problems we saw over and over were things that really could have been managed, 10 years before people chose or had different lifestyle information given to them. Of course, it was, that didn't make me develop the desire to do primary care necessarily, because a lot of what I saw was a result of people with standard kind of primary care coming through the ER with all kinds of problems. A couple of my colleagues, one was a surgeon, a general surgeon, one was another emergency physician, started doing some training through an organization called the American Academy of Anti-Aging Medicine, and were telling me sort of enthusiastically about all these things they were learning that they'd never learned in medical school, and things about lifestyle, nutrition, mitochondria, hormone replacement, regenerative medicine, things like that. So I kind of started to think about that. And then, not to get too in detail, but my father developed colon cancer, and I started frantically reading and trying to realize there's a whole world outside of kind of what I would call conventional or mainstream medicine that I knew nothing about as I was trying to figure out how to help him. That led me down a bunch of rabbit holes, led me to meet a bunch of physicians who looked at things very differently. And I started just kind of pursuing that, and ended up deciding, after doing a fellowship through the American Academy of Anti-Aging Medicine, also called the A4M, to take the leap and start trying to practice an alternative form of medicine. So I slowly worked myself out of emergency medicine and into practicing this kind of regenerative and anti-aging type medicine paradigm. And it's complicated. It's not easy. It's not been quite the same as being in a traditional medical model by any means, but it's the thing that interests me the most, for sure.
Yeah, I get it. And, obviously, for those people who are listening, who are also Wealth Formula listeners, which is most right now, I think, people have probably seen Rob in action. He's a veritable encyclopedia on just everything longevity and related stuff. So that the talk that you gave at our last Wealth Formula event was very popular, and the shows that you've been on, even on Wealth Formula podcast. So thank you for that. But we want to talk a little bit something about which I know is a pretty significant part of your daily practice today, and it really is related to hormone therapy. And we talked a little bit about this is a big topic, right? There's lots of different things to talk about here. And it's also a big topic for both men and women, and they're not the same topics necessarily. So we decided to do sort of two different podcasts. So thank you for doing that. But let's start with men, just for people who maybe don't have a good idea. I mean, everybody knows testosterone, it's the main hormone, blah, blah, blah. But tell us what happens with these kinds of male sex hormones over time, and what, when you're young, and then, when you're At what age does that start to change, and so on?
Sure. So, everybody's kind of heard of testosterone, as you uh, point out. And typically, once a male goes through puberty, probably say ages 18 to 25, their testosterone is about as high as it's ever going to get. And probably in their late 20s or early 30s. And again, this actually is sort of interesting because it's very different than it probably used to be. Testosterone levels start to decline in men. And the common teaching has been they go down about 10% per year until you get to be, say, 100 or whatever. And it's all,
Beginning around 30? Is that right?
you don't see it go up typically after 30. If you're, fortunate, it'll probably stay about the same. It'll kind of stay in its peak range
Yeah.
until a man is maybe, say, 35 to 40, and then it definitely seems to decline. Now, what's very interesting to me about this, and you can find this documented all over the place, is average testosterone levels in men have actually decreased significantly over the last 50 years. Apparently, during the Framingham Heart Study in Massachusetts back in the 50s, where they did all the lab work of all the men in the town of Framingham and all the women too, they recorded like a 25 to 30% higher testosterone level on average in age-matched men than we do currently.
Wow, that's incredible. Why do you think that is? Could it be a testing type of error too, or what?
That's a great question. It certainly could be. I mean, obviously, lab techniques have improved, sensitivity of and ability to measure things have improved. But and then those of us who are in this field kind of wonder what is the problem here. And I think my sense is, like probably everybody else, is number one, we really don't know for sure. Actually, interestingly, there's been decreases in male fertility recorded. You may have seen the studies out in the last 10 years or so. We think it's probably multifactorial. It's probably a combination of, our food environment, our light environment, our, overall sort of general stress and cortisol environment, probably due to endocrine disruptors in some of the things we use, like plastic water bottles that contain something called BPA. Now a lot of people have caught on to that, and they say, why does my water bottle say BPA free? Well, it doesn't have BPA anymore in it. It's probably
Yeah.
it's just as bad. Just no regulator has identified what that is. So there's all kinds of factors, and it's surprising to me. But as I've done this hormone replacement part of our practice for the last 7 or so years, we keep seeing younger and younger men coming in saying, gosh, I just don't feel good. And my testosterone, I wondered about it and I checked it and it was really low. Patients in their 30s and early 30s that are a lot lower than they really would have been maybe 20 years ago, or maybe lower than they should have been.
Well, it's interesting, and I mean, I guess that's another show entirely, like why testosterone levels are going down, and because I hear even like in young men that on average they're a lot less than you're talking about the Framingham study. I don't know how old those patients were, but even men in their teens and 20s that have average testosterone scores that were significantly less than they used to be.
Yeah. And to be clear, there is, I'm not an endocrinologist, and there is an endocrinologic kind of workup for young men with low testosterone, right? There's
Yeah,
potential diagnosis like pituitary tumors, and,
sure.
obviously there's primary hypogonadism where the testicles have been damaged in some way or something. So there's different reasons for it.
Yeah.
And so those aren't the patients I treat, not patients in their 20s who have low testosterone, but it's the general declining testosterone with age that is seemingly more common than it used to be.
So let's talk a little bit about the signs and symptoms of what low testosterone, declining testosterone levels might be.
Sure. So, it's, of course, people always think, oh gosh, it's all about sex, but that is absolutely not the case. Testosterone is a critically important hormone. There are testosterone receptors in nearly every cell in a man's body. So the symptoms of a declining testosterone usually are things like decreased energy, irritability, depressed mood, anxiety, poor sleep, lack of motivation, lack of ability to sort of set goals and follow through. Things that you could just, when you were 25, you just set a goal and say, hey, I'm going to get this done and just knock it out. Sometimes men, as they age and their testosterone drops, they can't. From a physical standpoint, oftentimes inability to build or maintain muscle mass. Insulin resistance goes up as testosterone goes down. So that, of course, predisposes men to gain weight and develop type 2 diabetes potentially. Testosterone is an anabolic hormone, so it helps to heal men in general, and women, actually. We can talk about that in a separate discussion. But so a lot of men will come in and say, gosh, every morning I wake up and I'm stiff and I'm sore and I just don't feel like I got a good sleep and I can't get out of bed, or I get out of bed in the first hour of the day, I'm just stiff. Oftentimes, testosterone therapy will alleviate that, just because it improves the kind of remodeling of joints and the damage done the day before. And then, of course, there's obviously the sexual side of it. There's a decreased libido, a decreased erectile function, and those are certainly reasons some men seek us out. But in general, it's quality of life. I mean, I hear so many men come in and say, I just am tired and I have no energy, and I, have dinner and fall asleep on the couch. And after we start them on therapy, they say, you know what, I'm motivated. I'm starting to work out. I'm doing stuff. I don't crash in at 7:30 at night, etc.
There also seems to be a number of more silent risks, right? The things that maybe you don't notice necessarily on a daily basis. Do you want to maybe talk a little bit about that?
Yeah, I mean, the other thing that I think is apparent is testosterone is an important hormone to maintain health, right? It maintains muscle. So think about this: your heart is a muscle. With a lack of testosterone, the heart muscle will eventually weaken and not be able to rebuild itself and become stronger. It also helps to maintain bone mass, so prevents osteoporosis. There's some suggestion that, certainly we know quality of life wise, men have better focus and concentration. And I think maybe one could potentially, project that out to maybe lower risk of dementia or cognitive decline as one ages. It's tough because you can certainly find studies, and I have a really nice kind of infographic I use in the practice that I show men that, overall men with low testosterone have much higher all-cause mortality, much higher risk of diabetes, cardiovascular disease, osteoporosis, etc. But the studies on this stuff are low, and they're mostly association-based and correlative, as opposed to randomized, double-blinded, placebo-controlled stuff, trials that we love to talk about in medicine. But yeah, it's so what we tell our patients is testosterone not only has immediate quality of life benefits, but it has potentially very significant long-term benefits towards maintaining lifespan or health span. You and I have talked before.
Right.
We don't really have any good data on lifespan. It's too hard to prove that.
So Rob, let's talk about what those numbers actually are, though, because I know, high, low. We've talked about, urologists sometimes will say, if you're as long as you're over 300 on your total testosterone, you're fine. How do you look at that? Or maybe, even a better question might be, how should people look at that who, are just dealing with this through their primary care physicians and looking at readily available numbers?
So the first thing I would say is, from a kind of an optimal health perspective, is we like to keep a man's free testosterone in the top quarter of the range. So everybody will have slightly different lab work. Different labs have different ranges. But I think for most of the people out there, I would always, if you're asking your doctor to check your testosterone, you should be very specific that you want not only a total testosterone, but a free testosterone also. And then what you're looking for is to take whatever the range of that free testosterone is. So say the range is 50 to 250. Okay, that's a pretty easy set of numbers to work with. You want to divide that range, draw a number line on a piece of paper, and 50 at one end, and this is what I do, honestly. 50 on one, 250 on the other, make a mark halfway in between, which is 150. Make marks at the quarter intervals, right? So that you're going to have a mark at 50, 100, 150, 200, and 250. And you want your testosterone to be in the top quarter of that range. This is free testosterone we're talking about.
That looks like it. That sounds like a Khan Academy type of thing that you're talking about right now.
I actually have my handout, and it's basically that number line. And
Yeah, no, that's great.
the lower quarter of the number line, it's red, and it's say this is where you don't want to be, and the top quarter is green, and this is where you want to be, and anywhere between that, you'd rather not be, but you're not in danger.
Got it. Okay, so let me ask you this question though, because we've talked about, like, if you're in these, now you're talking about data, you've got numbers here, and you go into, so you go into your doctor's office, and routinely he's testing, or he or she is testing you, and you've got low testosterone or free testosterone, but you don't feel bad at all, right? You don't feel bad at all. But we just said there's, potential risk, cardiovascular risk, cognitive risk, etc. If you don't feel bad or feel like there's something wrong with you, but your testosterone is really low, is there an argument to go ahead and replace testosterone even if you're not symptomatic?
Well, from my perspective, you don't feel bad when you have high blood pressure or when your
Right.
is elevated, and yet we treat those all day long, and we
Yeah.
standard of care. So the other part of that argument I would make to people is you may not feel bad, but you may not know how good you can feel,
Yeah.
right? So one of the challenges with what we call andropause, the male aging process, where your testosterone, where these hormone levels drop, is it's a uh, slow degradation of quality of life. And so, a lot of guys will go along and they'll just say, "Well, I don't feel bad. I feel fine." And yeah,
Maybe you forgot what you feel like when you feel good, right? That kind of
exactly.
thing.
So, I think if one could make an argument to replace it and see what happens, and if you don't like it, if it doesn't improve your life, then I certainly wouldn't tell you to stay on
Yeah.
it. Like, get off.
Yeah.
I,
Well, when we talk about, so let's talk about, before we talk about getting on it, let's talk about, there's all sorts of other things that you read about, people are talking about, that might be able to increase testosterone naturally. One of them is like, weightlifting, but then there's other things out there. I know, like Tongkat, vitamin D. People have talked about the link, bringing testosterone up just through that. Um, some other crazy ones like less masturbation. I heard that one, which I literally heard a guy talking about this on a podcast, and I looked it up, and I see no data on this, but it was a pretty well-known medical podcast, and I was kind of like dumbfounded. But anyway, we'll come back to that specific topic in a second. But what about Tongkat and some of the other supplements?
so obviously we see the end point of a lot of patients who've come in and tried those supplements, and my sense is that all of the non actual testosterone replacement, and let me put aside medications for a moment, all of those methods will maybe get a guy 10% at best. Um, some of the supplements out there, if you look very carefully at their advertising, they say things like increases free testosterone. So you might have a supplement like Tongkat or ashwagandha. There's a whole bunch of formulations out there with a variety of different herbs and things, and most of those are adaptogens. They decrease stress and things like that. And it seems like they might raise a man's testosterone maybe 5 to 10% in our experience. Resistance training, high protein diets, making sure you have adequate zinc are all said to help increase testosterone. But it's sort of like trying to plug the dike. When a guy's got a when a guy's testosterone is a lower quartile, you're not going to bring it from the bottom of the range up to the top of the range by taking any supplements or by lifting weights, etc. It usually takes some level of intervention. And part of that's just because at some level we are programmed to have a decrease in testosterone as we age. It's just
Right.
the order of things. It seems to be accelerating faster now than it used to, or it seems to happen sooner. But it is a quote normal thing that happens as we age. But let me give you a corollary to that. When I was, a lot of patients will say, "Hey, should I do this? Isn't this just normal aging? Shouldn't I just age normally?" And my kind of maybe flippant sounding answer to that is, well, when I was in the emergency department and somebody came in with acute MI, we could have stood back and said, hey, this is just normal aging. Let's just see how you do. Let's see what your myocardial function is. Let's get you survive. If you do, then, you know, you just live with the consequence. So, you know, I view my job, my practice in hormone replacement as very similar. We are taking our medical knowledge and intervening to help people have a better quality of life and hopefully life or health span. I want to get careful on that.
Yeah.
So why would we not replace it if we can do it safely?
Any comments on the masturbation decreasing testosterone?
You know, I haven't done the research specifically. I've seen similar stuff. I just can't see, you know, I think the theory there is you're using it up or something like that. I don't see there's relation to that. I've never seen the research, though.
Yeah, I thought it was pretty remarkable, actually. This, you know, like I said, I was listening to a podcast that's actually very high ranked podcast in hell, and people talk about it all the time. And but there was somebody who was interviewing on that show who just came out and just, you know, it was very clear as day. It was like pornography and masturbation will bring your testosterone down. I'm like, really? I had no idea. So I looked it up. I tried to find any sort of paper on this topic. I couldn't find anything. So I'm not convinced. But I mean, the theoretical idea is that apparently, you know, when you're doing that, you're effectively releasing prolactin, which decreases LH, and then LH will decrease testosterone. But I've seen no data about that. So if anyone hears that out there, don't listen to it. And if, you know, you got to do what you got to do, right?
Yeah, you know, there's also been similar stuff out there about, you know, retaining semen and it improves your focus and clarity. And I don't know. I mean, that's hard to research that stuff.
Yeah.
But again, I don't think you're going to see some guy go from bottom quartile, the red part of my little number line, to the top of my number line by, you know, abstaining from masturbation or taking, you know, whatever you can buy at the local GNC, unfortunately. And again, I'm seeing the bias sample. I've seen guys that have tried that. I'm seeing guys who've said, hey, I've been taking this and you know, I just got my labs done and here's where I am. So I see a lot of the failures of that. I don't see the successes clearly in my practice. But it seems to me like one needs to actually replace testosterone with testosterone if one wants to raise one's testosterone at some level. There is an alternative, which we can talk about, which you may intend to ask about, which is clomiphene.
Yeah, and actually that would be the next thing to do is like, let's talk about the options for treatment with medical intervention, basically.
Yeah, so there are definitely men who we would like to not start on testosterone right away. And the primary reason for that is fertility. When we replace a man's testosterone, it essentially cuts down or substantially decreases man's own testosterone production because the brain, which controls all this stuff, says, hey, there's plenty of testosterone floating around. I don't need to make any more. So it shuts down the production of two hormones, one you alluded to. They're called FSH and LSH, luteinizing hormone and follicle stimulating hormone. And those are what essentially talk to the testes from the brain. They're secreted by the pituitary gland. And they tell the testes to produce sperm and testosterone. So if I give you testosterone, your brain's like, hey, I don't need it. I got plenty.
Yeah.
It's down the production. So there's this theoretical risk of decreasing a man's fertility once we give him testosterone. Now
you're saying that's just theoretical? It seems like it just would, right? I mean,
I will tell you that I had patients father children while on testosterone. So,
oh, is that right?
Yeah, and I'm very careful to tell men, hey, there's a risk here of decreasing fertility, but this is not birth control. If you're not interested in potentially becoming a father, then you need to take other actions. So you know, I'm sure there's probably been somebody that's looked at sperm counts and things like that, and I haven't gone that far. But so we see a select group of men who are, say, between 30 and 40 years old, and we try to sort of limit ourselves to the 35 to 40 range. And those men are still interested in fertility. So an alternative way to raise their testosterone is to give them a medication called Clomifene, or the brand name is Clomid. And there's still a lot of controversy as to how exactly that works, because like a lot of drugs, it seems to have about 3 mechanisms of action. But essentially, it mimics the LH and tells the testes to produce more testosterone.
Well, that's also the medication that's used for fertility, right? Like when you're trying to like a woman's given a bunch of this stuff, and it essentially raises the levels of all of these hormones in the body, and effectively that's kind of what you're doing, right? With Clomifene, you're not only just increasing testosterone, but you're also increasing other sex hormones as well.
Yeah, and it also has some spillover effects on the brain in terms of estrogen receptor, activation and things like that. But yes, we can give men Clomifene in an effort to stimulate their testosterone production, and it is a variable success. Sometimes, I think we've had a few patients who we've taken out of the red zone, the bottom quartile, up into the green zone, but that's a minority. Most men get about a 25 to 40% bump in their testosterone from taking Clomifene. And we've had some men that don't seem to respond at all.
Real quick question for you on this. How much variability on a day-to-day basis is there in testosterone in men? Like, for example, say you're sick one day, or how much variability is there? Because for testing, obviously that's going to make a difference too. It's not like we have a hemoglobin A1C type situation for testosterone, right?
It's about 5% or so. So if I test you today and it's 250 total, and I test you tomorrow, it might be 275 or 237.
Okay.
But it's not going to go from 250 to 1,000 in a day.
Yeah.
I think once a
Okay.
man's kind of down there, you're down there, and it does vary based on time of day. There's a diurnal or a circadian rhythm to it, and there's probably a variability based on the last week of whatever you were up to or not up to, et cetera.
Okay, so let's talk about sort of the, I guess what you would maybe call the gold standard of treatment, testosterone. Maybe talk a little bit about, the way that's delivered, the different options that people have, that kind of thing.
Sure. So when we determine a man would benefit from testosterone replacement, and we've moved past the idea of Clomifene, and again, we try to use that in our younger patients because, by the way, as men get older, they just don't respond very well to it. But we can replace their testosterone. And there are typically three ways I consider replacing testosterone in a man. The first one is topical. And topical testosterone came into favor. And actually, the whole kind of low T thing started back in the early 2000s with a product called Androgel. And, you start seeing commercials on TV. Hey, do you have low T? And that's when testosterone replacement came into the public awareness. But in general, my experience, and that of my colleagues with topical testosterone has not been that great. Topical means rubbed on, typically as a cream or a gel. It needs to be done consistently, meaning every day. It's best to rotate the application sites, so it's going to be different on one day than the next because of the way that testosterone is metabolized in the skin. And it's hard to get and maintain a consistent high level of testosterone because absorption is variable depending on the state of hydration, where you put it on, all sorts of things. And then the other thing I've seen with topical that makes me not so much a fan of it is transfer to other people in your life. So you put a lot, and men have to put a high enough dose of topical testosterone on their body to get a reasonable dose in their body. A large part of that, and as an example, you need to put on maybe 100 milligrams a day to get, say, 10 to 15 milligrams in your body.
Where do you put it usually?
In eyes, usually. Actually, there's some suggestion that putting it on the scrotum is a better place to put it, although we found that to work better, but still not optimally.
Yeah.
But if you put it on your arms, say you rub it on your arms and you go to hug your daughter, and now your daughter is, maybe starting to grow a mustache or something like that.
Yeah, or your dog, and your dog becomes like a very mean, angry.
Yeah, well, and I have more than a few pet and child anecdotes from patients in my practice. I mean, I've literally I was using testosterone topically, and then my dog did this, and my vet's like, giving this dog hormones, So
Yeah. So it sounds a little bit harder to control the level, so what are the other options?
So another option is oral. you can take your body does not expect testosterone to come through your stomach. So it goes into the portal vein, into the liver, it gets
Yeah.
metabolized. I'm not a fan. Some people will prescribe a sublingual, meaning under the tongue, a troche that you dissolve under your tongue. Again, you end up swallowing a lot of it. Not as much gets in your bloodstream as you'd like. There's a lot of side effects, and you have to give a man a huge dose orally to get a small dose in the body. So really that brings us back to what I think are the two best methods for testosterone replacement in a man. One is injectable testosterone, and one are these hormone pellets. So with injectable testosterone, it's best done at least twice a week. So we train our patients to do the injection themselves at home. And we have a lot of patients that do that and very successfully. And we recommend injecting it what's called intra or subcutaneously rather than intramuscularly. And basically what that means to the listener is a subcutaneous injection is a very, very tiny, like a ½ inch long, very thin needle. So it doesn't hurt very much. An intramuscular needle is about 1.5 inches long, and it's a somewhat larger needle, so it does hurt more. And all the studies have shown that subcutaneous injection of testosterone gives great testosterone levels. It's less painful. There's less risk of causing damage to the muscle or scarring or infection. So we recommend subcutaneous injection twice a week for most of our patients. Optimally would be daily, but some people won't inject at all. Most people are willing to do it twice a week.
Yeah.
Asking people to do it daily is a big ask.
How about the pellets? What's that all about?
So the majority of our male patients prefer subcutaneous hormone pellet implantation. We have these little pellets, and they look a little bit like Tic Tacs, if you can imagine. They're little white cylinders. They're 4.5 millimeters in diameter. They're maybe ½ centimeter long. Each one is 200 milligrams of testosterone. So what we will typically do is apply a little bit of local anesthetic like lidocaine, usually to a man's flank or buttocks. We prefer the flanks for a variety of reasons, but they can almost be put anywhere, honestly. And then we insert anywhere between 6 to 10 of those pellets under the skin using a little kind of surgical instrument called a trocar. Sounds brutal and horrible. It's really not. It's an easy office procedure. It takes about 15 minutes to do. We do it sterilely, obviously. And most men really like it because they only need to have that happen 3 times a year. So for about 4 months, they'll have a very consistent, optimal level of testosterone. And then they come back 4 months later and we do it again.
That's interesting. So how do you titrate that? I mean, like, because in terms of if you're going to put pellets in somebody, you probably want to get it right the first time.
A couple good things are to know. Number one is testosterone has a very wide therapeutic index. You're not going to kill somebody with too much testosterone, unlike some of the things we do in medicine.
Sure.
And we kind of know, like, when you're 20 to 25 years old, most men make about 10 to 15 milligrams of testosterone per day. That's what their body makes. So, we kind of figure out over 120 days, if we say put in 1,800 milligrams of testosterone, so that would be 9 of these 200 milligram pellets, that's about 15 milligrams a day.
So they're all they're like time released. They're time released pellets.
Correct. I mean, they're not that technologically sophisticated. It's basically just testosterone that's compressed into a pellet with a tiny amount of cholesterol or another binding agent to hold it together. But the body dissolves them slowly over about a 4-month period of time. And they've been in use since the 1940s in Europe and elsewhere in the world. Not used that much in the US, unfortunately.
Yeah. That's interesting. But this is, I think you said this is the predominant, the preferred method in your office, though.
Probably 80% of our male
Yeah.
patients are on testosterone or on pellets, probably 15%, maybe probably more like 18 are on injectable and 2% are on topical. And those guys usually it's just a matter of time till they say, let's try something else.
Yeah, right. Exactly.
Pellets work very well. Now they're not perfect. It's not 100% time release where it's the exact same level until the day before your 4-month pellet insertion. It's the pharmacokinetics are such that the level's higher during the first few weeks to a month, and it gradually works its way down, and then in the last week or two, it tends to plummet fairly quickly. There's a small risk of infection, which we try very hard to avoid and don't have very many. There's a small risk of what we call pellet extrusion. So a month or two later, a guy will come back and go, well, this thing's poking out of my skin and it's a little painful and it's a little pellet out. But that's uncommon. That's like 1 or 2% of the time. And, and over time, after multiple insertions, there's a small risk of scarring at the site. But other than that, it's a very safe and effective method. And most of our patients love it. It works very well.
You talked a little bit about, the way that that the testosterone is actually metabolized and it goes through the liver, that kind of thing. When you're taking it orally, it makes me think about my father's for a period of time he was on some testosterone, and I'm pretty sure he was taking oral testosterone. I don't really talk. He doesn't really tell me anything, but he ended up with a portal vein thrombosis, which I think is a very serious problem. And he was anticoagulated for that. Do you think that that's primarily a risk with, and you can talk about risk broadly, but with that one in particular, is that something that primarily would be from taking oral testosterone because of the metabolic pathways there?
That's a great question. I've never looked at portal vein thrombosis specifically with regard to oral testosterone. I will tell you that, the risks of testosterone, both pellet therapy and injectable therapy, the things that we need to be medically managed are men tend to see an increase in their hemoglobin and hematocrit. So for the lay public out there, we'll just talk about the hematocrit to make it easy. That's the proportion or fraction of red blood cells in your blood. So blood is made of plasma, white blood cells, platelets, and red blood cells. And most of it's red blood cells. So that's why your blood is red. So what we do see in men is the average guy walks in the front door, his hematocrit is, say, 45, meaning 45% of his blood is red blood cells. In about 20% of our patients over time on testosterone, that hematocrit it can go up a little bit. So, and the theory and the theoretical problem is if it goes up too high, say you get your hematocrit to 55 or 60, now your blood is all red blood cells.
Right.
And that could lead to thrombosis or clots. And
Right.
so
Right.
why you see these ads on late night TV, did you have testosterone and have a blood clot or a stroke? We'll call, this attorney and we'll get you money.
Okay, so there's money at the end of the rainbow here, if we can.
But but honestly, if your doctor is replacing your testosterone, part of their job is to manage and keep an eye on your hematocrit. And we're not entirely sure why that is. We think it's because it actually helps with iron absorption. In men, you tend to absorb more iron out of your gut when you have optimal testosterone levels. So, the first thing we tell our patients is, hey, don't take a multivitamin with iron. If it starts to get too high, maybe avoid or cut back on iron containing foods. Don't cook on cast iron. There's a bunch of ways to manage that. But so I don't know about portal vein thrombosis. I will say that we worry a lot, or we monitor our patients carefully for their hematocrit to be elevated. And we've never had a patient with a blood clot in 7 years of doing this. I've yet to have a patient that's had an adverse effect.
That's a lot of patients too. So that's a pretty good track record. Good. So overall, we've talked about testosterone, probably a good idea for a lot more men than actually are actually on it. Another thing that people have been on for a few decades now is this human growth hormone. And I'm curious about your take on this because, I've never been on it, but I've heard about people when they're on human growth hormone, they just feel fantastic, right? Like, it's like the best thing ever. And maybe talk a little bit about why that is, and then, if that's the case, why aren't we all on it?
Sure. Actually, Buck, before I move to growth hormone, let me just throw one other thing out there. I was talking about the potential problems with taking testosterone. The other thing that we have to monitor very carefully is a man's estradiol level. And so we do that carefully and we treat that when it gets too high, just as we treat the hematocrit when it gets too high. But just so you're, just to kind of close the loop on that, if you're
Oh yeah, for sure.
testosterone, that's important. There's a lot of doctors that will treat a man with testosterone but not monitor or treat estradiol when it gets too high. And estradiol is a hormone made from testosterone. We think of it as a female hormone, but it's very important in men. You need some, but you don't want too much. So
Right. If you have too much, if you get too much, you'll end up with growth of your mammary glands and things like that. And is that
and as one of my colleague says, you'll cry in the grocery checkout line when you see the cover of Vogue, for example, and things like that.
right?
Well, I mean, it can lead to emotional lability, and as you
Is that right? No kidding. I
said,
didn't know that.
fluid retention, prostate enlargement,
Right.
all kinds of bad stuff. Anyway, to move on, human growth hormone. So, in the anti-aging world, the first thing we do to optimize human growth is to optimize testosterone, because oftentimes we can see a slight bump in human growth hormone levels when a man's testosterone is taken to optimal. So I would never start with HGH. HGH is a complicated hormone. It's released in the middle of the night from the pituitary gland at around 2 a.m. or so. I would say everybody's a little different. So we don't really have an easy way to measure it in the human body unless you wake someone up at 2 a.m. and measure HGH levels. So we measure other proteins that are kind of proportional to your HGH level. I'm kind of, from my perspective, the jury's a little bit out on HGH still. There are a lot of patients that feel better on it. It seems to help with recovery and skin and hair and exercise and all kinds of things. But the flip side of that is and I'm going to have to struggle through the specifics, but there's a tribe in South America that's been studied extensively by longevity scientists such as Dr. Longo at USC that has a defective gene for making HGH, and those people live longer and have less cancer than people with so-called normal HGH levels.
That's really fascinating to me. So first of all, if they have too much human growth hormone, are they all giants though? I mean, because obviously,
They have no human growth hormone.
oh, they have no human growth
Very
hormone.
small. They're very small and short. Active HGH, um, production, and yet they are absent of all kinds of other medical problems. And so,
Well, if you think about, so this is kind of where I was going with this, right? Is I've never contemplated even, despite people sounding like, you feel like you're Superman when you're on it. Uh, if you look at what human growth hormone also does, I mean, it releases, you've got a bunch of cortisol flowing through your blood in response to that, and then that's going to increase probably your insulin resistance. There's a whole bunch of downstream stuff that I don't really want to get into personally for my own body, but people love it, right? But I can see how there would be potential problems with it. Maybe you feel good in the short term, but the long-term implications of it might not be what you want. So maybe you feel great now, but you die 10 years early, right?
well, that's the worry, and we don't know for sure.
Yeah.
We're pretty comfortable. I mean, and when I say we, I mean the read of the literature and the sort of feeling in the room at the anti-aging medicine meetings is we're all very comfortable with testosterone, and it's not going to accelerate your life and flame you out more quickly. And as far as HGH, you need the right amount when you're young, and you need some when you're older. But having it right at the top when you're older might actually lead to a shortened health span or lifespan, or maybe it'll increase your, it's sort of like throwing some lighter fluid on the fire of your life. Now we don't know this for sure, and there's still some valid reasons to do it. Some people will cycle it. Some people will do it for a short period of time, say 6 months, and then try to, leapfrog forward with their conditioning. The one other thing I'll say about HGH is it's actually a very difficult hormone to prescribe. There are doctors in various states who've lost their medical licenses for prescribing it for off-label use. It's the only hormone that's regulated by Congress, interestingly. And part of that is probably because of the backlash to movie stars and sports, figures using it. So And it's also very expensive. Testosterone might cost you $20 or $30 a month. Human growth hormone is around $1,200 a month. So it's very much out of the reach of the average person. There are some peptide hormones that cause an increase, or some peptide medications that cause an increase in human growth hormone release that I've got some patients on. We do them for, say, 3 months at a time, and they report feeling great. It increases your HGH. It does so in a way that is a little more controllable than giving someone human growth hormone, because we don't overwhelm the human growth hormone receptors. We tell the pituitary to secrete as much human growth hormone as it can, but there's still a negative feedback loop. So there are some alternatives to HGH which are very promising. They're very difficult to get in the state of California now, but in other states they can be uh, acquired. There's a drug called sermorelin that does something similar that we can get in California.
Is that a peptide, or is that?
It is a peptide, but it's an FDA approved peptide. In other words, it's an actual drug.
Got
It's
it.
been through the FDA approval process, et cetera.
How can just a few more words about peptides, because that's another buzzword, right? Like people want to hear about that, and you're specifically talking about a peptide that might raise human growth hormone. But are you also, I presume you're probably also looking out for, okay, what's happening then with our cortisol levels, what's happening with our insulin resistance? You're probably paying some attention to that. Are you seeing any of the net results of the same results that you would with a direct human growth hormone?
Overall, on the few patients we have on those peptides, we do see overall health improvements. So insulin resistance and things like that seem to decrease. Their body
Really?
comp better. But those are people that are very committed. They're not only getting testosterone replacement, they're typically working pretty hard to improve their health. Because of the prescribing situation around the peptide hormones in California, we don't have a lot of patients on those at this time.
Yeah. Yeah.
Now, elsewhere in the country, Florida, there are doctors on every corner I
Yeah.
can prescribe that, so it might be better to get results from them.
Let me ask you, let's conclude this, the men's hormone podcast on, I guess, some things that are maybe a little sensitive, but maybe some guys have some problems, and I think it's a good idea to talk about. It's male performance issues. So you mentioned at the beginning here that it's not like, okay, performance, specifically any sort of impotence, et cetera, is not necessarily directly correlated with testosterone levels. So then what is it correlated with?
So what I tell patients is that testosterone is a necessary but not sufficient component of good erectile function. So we obviously take care of a lot of men who come in either primarily for erectile function issues, or, oh, by the way, I've got this. And, as you say, it's sensitive. I will say most men don't like to talk about it. It strikes at the very high, the core of the male psyche and popular culture. But so erectile dysfunction as a man ages is usually actually caused by atherosclerotic disease. It's felt to be the most sensitive indicator of atherosclerotic disease. In other words, a man who's having problems getting erections probably has some level of heart disease and brain disease from coronary artery atherosclerosis and cerebral atherosclerosis. But it's a very sensitive tissue. Everything has to work right to have an erection work well. So what we have found in our practice is uniformly the most promising treatment for erectile function is not the drugs. Everybody's heard of Viagra and Cialis, and those do help by increasing nitric oxide signaling, which helps dilate blood vessels and et cetera. But is a technique known as low intensity shockwave therapy or acoustic wave therapy, or goes by a brand name called GAINSwave. Really amazing technique, but we actually use a medical device to apply pressure waves to tissue, and it helps to restore flexibility to blood vessels. It helps to break up atherosclerotic plaque, and it actually helps to create a signal to the body to regenerate tissue.
So wait, let's back up real quick though. Like, what's your algorithm for this? Do you start out with, tadalafil, or low, I guess there's a daily one, and then do you try that first? So how do you generally approach this problem?
Well, so a lot of guys that come see us have already tried the phosphodiesterase inhibitors. That's the class of drugs that tadalafil is, and Viagra, which is sildenafil, Levitra, which is vardenafil. That's the class of drugs. They're called phosphodiesterase inhibitors. So a fair number of patients will come to us and say, "Hey, I've already tried these drugs, and either they don't work, or it turns out that the side effects are very significant for a lot of men. They'll get stuffy
Sure.
noses, headaches, runny noses. They'll have visual halos. Some of them get heartburn or gastroesophageal reflux. So a lot of men say, I don't want to take those drugs anymore. They don't make me feel good, or they make me feel bad. And some men say, I just don't want to take a drug. So
Yeah.
our
So
kind of pathway is
yeah.
to try to optimize testosterone, and if still warranted, we will try to get them to get shockwave therapy.
So the GAINSwave therapy, how in practice does that work? So people come in, I presume it's, in an in-office thing. How long does it take? How often do they need to be treated? That kind of thing.
So it's a kind of an innocuous looking medical device. It delivers, and I want to be clear, when I say shockwave, I don't mean electrical shocks.
It's a terrible, terrible thought going image there.
Yeah, and that is not the case. So maybe better call
Yeah.
it acoustic wave.
Maybe more, yeah, it's sound wave. It's basically sound
Sound
wave,
wave.
right?
Okay. Sounds much more correct.
Yeah.
So,
Yeah.
but it's a painless in-office procedure. Each treatment is about 20 minutes. It takes about 6 to 12 treatments, depending on what a guy's starting point is in terms of how bad their erectile function is. And then over about 6 to 8 weeks after their final treatment, we'll continue to see improvements in erectile function. And
So it's like once a week?
yeah, once a week, typically. It takes about 20 minutes. The logistics of it are, we bring a man in, they put a benzocaine lidocaine tetracaine cream, which is a numbing cream, on their penis. And that's more just for their comfort and the comfort of our technicians than it is because it hurts, because we do have guys that have done this with no pain, and no numbing cream. But, the treatment takes about 20 minutes, and it's just applying, it's almost like a wand to the penis, and it helps to regenerate the blood vessels of the penis. Now, I will tell you, if you search the literature on sound wave therapy,
Yeah.
wave therapy, there's over 80 published papers relating to treating men with erectile dysfunction. It's actually an amazingly cool therapy. It works for plantar fasciitis, diabetic ulcers. They're studying it for coronary artery disease. It's used a lot by chiropractors for musculoskeletal injuries and joint pain. So it's a technique that has broad applicability, and we just happen to apply it to men for sexual function. And by the way, it does something similar in women for sexual function. It's a really amazing technique.
How long have you been using it? Like, I'm curious what your clinical outcomes have been in terms of, obviously you may not have enough to do some sort of trial or study, or but anecdotally, what are you seeing big results from that, or?
We see great results. I mean, anecdotally, we started doing it in 2017, and we have treated probably hundreds of patients, and the vast majority, probably 80 to 90%, will report a significant improvement in erectile function. Believe it or not, there's a score that people use. It's called a SHIM score, a sexual health in men score, and it's a number between 5 and 25, and most guys after 6 treatments will see their SHIM score go up by maybe 4 to 5 points. And so we use that in combination with a few other techniques and things, and we can usually get a guy, back to reasonable erectile function. We've treated patients who've had no erectile function after having had prostate surgery, for example, and got them erectile function back. Now,
No kidding.
that takes a lot of work.
Well, but that when you say that though, what's interesting about that to me, Rob, is that doesn't sound necessarily like it's just blood vessels. It also sounds like there's some nerve regeneration going on there, because with those patients who are having prostate surgery, a lot of times they're having damage to the, sympathetic plexus or whatever, that's creating this. So what do you think's going on there?
Well, I mean, part of the treatment protocol is not only to treat the penis, but what we call the crura, the vascular pedicles of the penis, and also down
Mhm.
in here at the prostate gland. So we're
Okay.
treating that whole general pudendal area. And I think there's probably an increase. There may be some neurologic healing. In fact, I have a friend who is a chiropractor that's using acoustic wave therapy for treating neuropathy in diabetics, and he's seeing very good results with nerve regeneration. Clinically looks like nerve regeneration now. I don't have biopsies of these people's legs to prove it, but it's really a remarkable therapy. It seems to work for a whole bunch of things. And I will be clear, the guys who have the really serious damage from, say, a prostatectomy, they take a lot of treatments. That's not a 6 treatment project. That's a 15, 18, 20 treatments. The great thing about this therapy is it's extremely safe. There's almost no complications that I've ever seen, which might be the safest thing I've ever seen in medicine. And the treatments are sort of stack on top of each other. Like, there's a dose dependent effect. The more treatments you do, the better results you get. And, back to your first question, we've been doing it since 2017. We have some patients that had an initial series of treatments. It typically lasts a couple of years because guys will, we get older, whether we like it or not.
Yeah. Presumably that is that's not a insurance covered type procedure either. I mean, I'm presuming it's considered more cosmetic and that kind of thing. And so people, and I'm also presuming you got some people who come in just because they want to they just want to be better. Right? I mean, you don't have to have like a problem, but you want to be a superstar or something like that. And you go,
Search Ben Greenfield and GAINSwave, you'll see an interesting article he wrote in Men's Health that it makes it sound way more effective than we've ever found it to be. But yeah, this is a 30-year-old guy at the top of his game anyway.
That's funny.
But yeah, but we have patients who come in for monthly maintenance treatments, for example.
Yeah.
Because they find it works and they're willing to pay for it.
That's interesting.
Well, good stuff, Rob. Thanks for giving us this this wealth of information here on the men's side, and it's always great to talk to you. But we will be right back, and the next episode we're going to do is with women.
Sure.
Thanks, Rob.
Okay. Thanks.